Hi, everyone. I'd like to welcome you today to our 1 hour presentation on understanding trauma and COVID-19, what school professionals can do to help. I'd like to introduce myself. I am Terry Sisson. I've been a school psychologist for 24 years in Virginia, and I've been working with PAR for the past 2 years, and I'm so excited to be here with you today. I will like to say that since we do have a large number of attendees, if you have any questions, please type them in the chat box, and we'll try to answer some of them at the end of the session.
Hi, I'm Dr. Carrie Chant-Morera, Project Director at PAR. Prior to joining PAR, I was a practicing school psychologist and licensed psychologist. We're so glad that you joined us today. Terry and I are really passionate about helping others and know that the topic of today's presentation is important to you. We have a lot of information to share. Each of these goals could be a separate presentation on their own. First, we will provide a broad overview of the definition of trauma. Then we will delve into adverse childhood experiences, positive childhood experiences, and some of the psychological effects of quarantine. Third, we will begin to explore the impact of trauma and COVID-19 on students. Fourth, we will provide strategies for how schools can prepare for students to return. Then we will share specific interventions and accommodations for specific problems that may arise in the school setting. Our sixth goal is to provide an overview of trauma assessment and specific assessments. Finally, we will share PAR resources to add to your existing trauma toolkit to help you feel prepared for the next school year. Overall, we hope that we will increase your knowledge and competence in these areas. We challenge you to come up with 3 things that you will do or follow up as a result of listening to this webinar.
So first, I'd like to go in a little bit of history of trauma and how it's evolved over the years. Probably the first documented research of trauma was by Jean-Martin Charcot, and he was a 19th century neurologist, and he was one of the first to connect mental illness with trauma. So you might not know his name, but you've probably studied him in Psych 101. He was the doctor that looked at traumatized women with symptoms he diagnosed as hysteria. So they had symptoms such as paralysis, amnesia, sensory loss, passing out. And from there, Pierre Genet was a student of Charcot, and he studied dissociative symptoms and personality development. After World War II, he put into place psychological first aid. Now, that's a lot different than what we think of as mental health first aid or psychological first aid, because this was specifically to help soldiers recover and return to their posts as soon as they could. In World War II, Spiegel and Gardner realized that relationships were extremely important in recovery. So a lot of their treatment revolved around keeping soldiers close to their unit and family members so that they could improve and get back into the community. Probably what they would consider more contemporary trauma theory occurred after the 1942 Coconut Grove nightclub fire in Boston, where 492 people died during that event. Dr. Lindemann treated many of the survivors, and he looked at grief, difficulties with problem solving, disorganization, and some of the other symptoms that occurred after that traumatic event. And around the same time, Parad was studying similar constructs with people who had undergone individual crises. And they really started to create this more contemporary view on trauma. Most of us can remember some of the trauma research around the Vietnam War because veterans were having a lot of chronic problems, such as difficulties coping with civilian life, alcohol and drug use, violence. Some were homeless or couldn't keep a job. So in 1980, with the DSM-3, that was one of the first times that they used the word trauma in the DSM with PTSD. And the definition of PTSD was heavily influenced by advocates for war veterans, battered women, and abused children. Um, more recently, we've been looking at what's called complex trauma or developmental trauma disorder, and that has been recommended a few times to go into the DSM. However, it hasn't quite made it there, and I'll describe some of the differences between these two as we go along. So, um, some of the changes of the DSM-5, it used to be PTSD used to be under the category of anxiety. However, now it's under a separate category of trauma and stressor related disorders. Generally, it's a single or series of traumatic events such as death, serious injury, or sexual violence, and these can be either direct, which means it happened to you, witnessing, that means you were there when it happened to someone else, or indirect, learning that a friend or relative was exposed to some sort of trauma. And it can also be repeated. So, for example, first responders or military people who are exposed to traumas on a regular basis. And some of the other trauma and stressor related disorders are acute stress disorder, adjustment disorders, reactive attachment disorder, and other specified trauma and stressor related disorders. Right now, complex PTSD is not currently in the DSM, but I would imagine with all of the research that has been done around adverse childhood experiences, which we'll describe in a minute, that they'll highly consider it for the next version. So in 1992, Herman was the first to suggest complex PTSD as a new diagnosis, and he wanted that to go in the DSM. However, at that time, there wasn't enough research behind it, and they did not put it in there. In 2004 and 2009, Courtois had a definition, which you can see up here. Um, it's the inability to self regulate, self organize, or draw upon relationships to regain self integrity, which is associated with histories of multiple traumatic stressors and exposure experiences, along with severe disturbances in primary caregiving relationships. Um, Again, he recommended that these go in the DSM, and uh, they were not put in the last DSM-5. So let's discuss the different types of trauma. There are several theories out there that may give more than two, but I'd say the most common theories of all the research out there are two different types: acute trauma and complex trauma. Trauma is generally a single event, it's sudden, unexpected. Most of us who have gone through graduate school several years back, we're more familiar with this type of trauma because it's the more typical definition of PTSD. Complex trauma tends to be more chronic problems of childhood. So it's interpersonal trauma, and it's involved with the ACE study, which Carrie will talk about in a minute. Um, One of the things that isn't listed here is tolerable stress, because that's not necessarily a diagnosis. It's a serious temporary response that um, that is in response to trauma. But with positive relationships and supportive relationships, the person recovers from that. So I think this is important to note because we might see some of this as students come back in after being quarantined, is that they may have some trauma like responses. However, that doesn't necessarily mean that it's complex trauma.
Let's talk about adverse childhood experiences, positive childhood experiences, and effects of quarantine, as all of these experiences will affect children in some way, and we will likely see some of the impacts in the school setting. A lot of what we know about trauma today comes from ACEs. This was a research study conducted by Kaiser Permanente and the CDC. Participants were recruited between 1995 and 1997 and have since been followed up for health outcomes. It originally started as an obesity study. I will tell you a little bit about the researchers. Dr. Folletti, he wanted to know why people were dropping out of the study, many after losing 100 pounds or more. He noticed that almost all were not obese in childhood. They did not gain weight slowly, but all at once, staying at their heaviest weight. So he conducted individual interviews with those who dropped out of the study. He asked them questions such as, how much did you weigh when you were born? How much did you weigh in first grade? And asked about their weight at various other points in their lives. When talking to one female respondent, he asked her, "How much did you weigh when you were first sexually active?" And she answered 40 pounds. He was sure that that couldn't be right. So he went back and re-interviewed. And of all the almost 300 people interviewed, he found out most of them were sexually abused as children. One woman even thanked Dr. Folletti for asking, and then she looked down at the carpet and muttered, "Overweight is overlooked, and that's what I needed to be." The second researcher, Dr. Anda, was at the CDC studying coronary heart disease. In his early career, he worked in the Veterans Hospital. He also worked in Wisconsin prison systems and studied young men with substance abuse issues and really wanted to know, how did they get to where they were? He also worked in the ER and studied the relationship between substance abuse and violence. So all of these experiences led him to his preventative medicine work with the CDC. Here's some more information about the ACEs study. There was no official end to the study, and the data points have been collected along the way. This study continues to grow, and the ACEs are studied statewide and nationally. Medical offices are even now using it as a screening tool. Research is also looking into the development of an ACE-IQ, which is the ACEs International Questionnaire. So let's look specifically at the ACEs. 10 types of childhood trauma are measured in the ACEs. The ACEs questions all refer to the respondents' first 18 years of life and their experiences. The 10 questions are presented in a yes-no format, and each one refers to a personal or family-related trauma. So the personal traumas include physical abuse, sexual abuse, physical neglect, and emotional neglect. The family traumas on this instrument include a parent who's an alcoholic, mother who's a victim of domestic violence, whether or not there's been death or abandonment in the family, if there's a family member with mental illness, if there's a family member in jail, and whether or not a parent is not involved due to divorce. So for each of the traumas endorsed, that results in a score of 1. You can score 0 to 10 on the ACEs. I want to point out that we realize there's other types of trauma, for example, racism, homelessness, and loss of a caregiver. However, the ones included on the ACEs have all been well studied in the research and mentioned most frequently by Kaiser members. Subsequent research has also explored the relationship between other childhood adversities and health. Evidence shows that factors such as bullying, community violence, death of a parent or guardian, discrimination, or separation from a caregiver to foster care or migration may also lead to a toxic stress response. So, how common are the ACEs? A whopping 2/3 of the 17,000 people in the ACEs study had an ACE score of at least 1, and 87% of those had more than 1. 36 states and the District of Columbia have done their own ACEs surveys, and it's notable that their results are similar to the CDC's ACEs study. More is worse. ACEs are related to some of the leading causes of death in the United States. 7 of the top 10. These include heart disease, cancer, respiratory diseases, stroke, diabetes, kidney disease, and even suicide. The amount of ACEs a person experiences has predicted the amount of medical care required as an adult with surprising accuracy. For example, in a study that was conducted by Dubey in 2003, they found that 1/3 to 1/2 of drug use in our country is related to ACEs. This is one of the first solid studies that showed a physical health connection, not just a mental connection. This chart illustrates just why childhood trauma is debilitating when comparing those who have 0 ACEs compared to those who have 4 ACEs. As we reflect on the ACEs and our current national climate, we need to recognize there is a potential for higher ACEs during school closures and the effects of the pandemic, including homelessness, poverty, food and job insecurity, family separation, grief and loss, parental substance abuse, child maltreatment, and mental health issues. When we talk about trauma and adverse experiences, it's important to talk about positive childhood experiences, or PCEs. PCEs are essentially the opposite of ACEs. Examples include having family, teachers, coaches, or leaders available to help children, having rules and structure in the home, and having someone you can trust in your lives. So how do PCEs affect us? They can serve as buffers to trauma. They can help protect people from developing negative outcomes in life. So as professionals, we need to ask ourselves, how can we begin to and continue to help foster PCEs? Improved mental health outcomes and a better quality of life can be achieved if children have PCEs. So here's a list of some competencies and things that will help lead to positive outcomes in children. Go ahead and take a moment and look at this list. In our work, what can we do to help? How can we facilitate an increase in PCEs? We acknowledge common traumas through ACEs and PCEs as resilience builders. With the COVID-19 pandemic, we need to address the effects of quarantine and how this may be impacting our children. In the reviewed studies cited below of quarantine, financial loss as a result of quarantine created serious socioeconomic distress and was found to be a risk factor for symptoms of psychological disorders and both anger and anxiety several months after quarantine ended. Although very few participants in some of these studies were extremely concerned about becoming infected or transmitting the virus to others, those who were concerned tended to be pregnant women and those with young children. Also, confinement, loss of usual routine, and reduced social and physical contact with others were frequently shown to cause boredom, frustration, and a sense of isolation from the rest of the world, which was distressing to participants in the study. Many participants cited poor information from public health authorities as a stressor, reporting insufficient clear guidelines about actions to take and confusion about the purpose of being quarantined. Participants also reported a perceived lack of transparency from health and government officials about the severity of the pandemic. Only one study that we could find compared psychological outcomes during quarantine with later outcomes and found that during quarantine, 7% showed anxiety symptoms and 17% of participants showed feelings of anger. Whereas 4 to 6 months after quarantine, the symptoms had reduced down to 3% for anxiety and 6% for anger. In a qualitative study conducted by CAVA in 2017, they reported that several participants described long-term behavioral consequences after the quarantine period, such as vigilant hand washing and avoidance of crowds, and for some, the return to normalcy was delayed by many months. Here's a look at how quarantine affects children more directly. Education being disrupted is the most significant effect, and due to this disruption, a variety of other things are disrupted in children's lives as well. Overall, life is chaotic. The consistency of schedules is negatively affected. There can be a lack of predictable rules and consequences. There's no longer set expectations to teach children how to behave. There's an impact on negatively affecting self-discipline and impulse control. And importantly, a sense of safety and control can be lost. Without schools in session, it's now up to caregivers to provide this in the home. And it's notable that for many children, they are safer at school than at home. This is having a devastating impact on thousands and thousands of children. Children are vulnerable to the secondary impacts of the pandemic. Vulnerabilities are related to what's going on in the home environment, including job loss, domestic violence, child abuse, uncertainty, and an increase in stress. Additionally, undocumented students and families may not have access to health care. When children lose their schooling, they miss out on many substantial supports that are listed here. Additionally, there are many disparities that we see during the quarantine. Inequalities are magnified when learning moves to the home environment. Stigma and racism may also occur as a result of COVID-19, including children and family members who test positive for COVID-19, those with allergies or asthma, which results in coughing and sneezing when around others, Asian American individuals, and African Americans for wearing face masks in public. As you can see here, there are many psychological effects of quarantine in children. Some negative effects include post-traumatic stress symptoms, confusion, and anger. Stressors included longer quarantine duration, infection fears, frustration, boredom, inadequate supplies, inadequate information, financial loss, and stigma. In a study by Sprang and Silverman, which was done in 2013, they compared post-traumatic stress symptoms in parents and children quarantined with those who were not quarantined, and found that the mean post-traumatic stress scores were 4 times higher in children who had been quarantined than in those who were not quarantined. In that same study, 28% of parents quarantined reported sufficient symptoms to warrant a diagnosis of trauma-related mental health disorder, compared with only 6% of parents who were not quarantined. You can begin to see how these results can result in adverse experiences for children. Now, let's briefly discuss the impact of trauma on the brain. Research on children's brains found that toxic stress damages the structure and function of a child's developing brain. It's important to note here that correlation does not mean causation. These brain changes are what happens with many people, but not all. Trauma is a risk factor for these brain changes. The first one here is that a smaller hippocampus may result. Chronic stress releases cortisol, which can reduce hippocampus volume. This is shown in veterans with PTSD. There's mixed results in traumatized children. It could be because the brain cells are dying off. Some studies showed decreased function as well with the hippocampus. The second is that a smaller amygdala may result from trauma. Children may have difficulties with identifying emotions of others and with their emotional regulation. The corpus callosum may also be impaired by trauma. Many elaborate connections to other brain regions, for example, in our right and left hemispheres, are affected, and many functions are impacted. Additionally, altered connectivity of the corpus callosum can be seen in individuals with ADHD, autism, bipolar, and schizophrenia. So, as you can see, trauma affects a wide, varied range of brain functions, including the cerebellum, the temporal lobe, and frontal lobe. I want to point out that these changes are not permanent. The brain can improve over time, but this is more likely to happen with a safe, stable, and supportive environment. Toxic stress sculpts the structure of the brain, especially early in life. In a typically developing brain, you have healthy neurons in the prefrontal cortex with many neural connections. However, when the brain is exposed to toxic stress, this results in fewer neural connections. This toxic stress can negatively impact health, behavior, learning, relationships, and social skills. For health, obesity, depression, heart disease, and or lung disease can result. Learning impacts of toxic stress include memory issues, attention concerns, difficulties with cognition and focusing, executive functioning problems. Some children may have a lower GPA or an increased risk of dropout. Toxic stress can be seen in relationships, as evidenced by having difficulty trusting others, boundary issues, difficulty understanding emotions, and a poor self-awareness. Other general behaviors that we see sometimes include dysregulation, mood shifts, hyperactivity, aggressiveness, withdrawal, perfectionism, dissociation, and it also may lead some people to have the belief that the world is a dangerous place. However, on a positive note, interventions and enrichments are the most powerful impact early in life.
Okay, so with all of that background, what can we expect as a result of COVID-19 and trauma when we go back to school? We've already talked a little bit about health, and we know from stress and trauma studies that health can be impacted in the ways that are listed here. Some of these will not show up until later in life, so they might not be something that you'd see immediately upon return to school. But mental health issues may be more immediate. For older students, they may turn to biochemical solutions such as nicotine, alcohol, or drugs in order to cope with anxiety and stress that they've experienced during quarantine. So we do have to look out for mental health concerns and substance use and make sure that we have a plan to call parents and or refer when necessary. More immediate concerns are those of learning. Students may have difficulties returning to school, especially those with anxiety. It's hard to leave your family and leave um, where you feel safe in order to go out into a public place, especially after what they've seen on the news or heard their parents talking about. Students coming back to school may have problems with memory, attention, cognition, and executive function. Sort of like if you've ever been at work when after you've had a death in the family and it's really super hard to concentrate. You're going through the day, but you feel like you're kind of a shell of who you normally are. We can expect to see things like that with students, which can certainly impact their learning. Studies have shown that students with trauma have weaker academics overall. They're more likely to fail a class or a whole school year. And if there's no intervention as they go along, they are more likely to drop out. A 2014 study did interviews with students who had ACEs with scores of 3 or more, and because and as you can see, these students self-reported that they were having a lot of difficulties with learning in the school, with engagement, staying calm, being attentive, and finishing tasks. And because these symptoms mimic other problems such as ADHD or ED, they can be easily misdiagnosed. And I think, especially right now with COVID-19, it's really important to give students time to adjust, especially if there were no difficulties prior to going into quarantine. These could be adjustment issues or just trying to deal with stress and anxiety that could be not long term. So we really need to give these kids some time to readjust. I think this chart really speaks volumes for how important ACEs are and function within the classroom. Now, obviously, these are with much younger kids because this is ACEs during the first 3 years, but it talks about whether or not if a student has a certain number of ACEs, they're more likely to be diagnosed as a student with a developmental delay. And as you can see, as the ACEs are lower, that percentage of the population is not often diagnosed with a developmental delay. But you get up to 6 and 7. If a student has 7 ACEs or more, they're 100% likely to be diagnosed with a developmental delay and placed in special education in their early years. When it comes to relationship and social skills, this is going to be a definite area of focus, especially after COVID-19. Many students have been isolated, some don't have supportive families, and some even have families who have high ACEs. So, research has shown that if a parent has high ACEs, they have a difficult time taking care of themselves, which in turn makes it more difficult to take care of their students. I mean, of their children. So, students like this will have difficulties with relationships upon their return, and they're often preoccupied with physical and psychological safety. So they may distrust other adults and they may be very unsure of their surroundings. And for kids like this, school can really feel like a battleground when they come back. They have an assumption that the world is a dangerous place. So, as we know, there are generally 3 ways that students or people in general respond to situations like this. They have fight, flight, or freeze. So fight are kind of our aggressive and defiant students. They're the ones that we would consider to be more socially maladjusted, oppositional defiant disorder, maybe conduct disorder. Flight um, is kind of those students that you see have more emotional dysregulation. They're impulsive, hyperactive. They may either escape or withdraw or actually try to elope and run away. And then there's freeze. This is the one that I think is most overlooked, and could be the most concerning because they don't necessarily get the help that they need. So I think it's really important that we look out for these students. They are the ones that are more withdrawn. They're not showing their emotions, so they're kind of stuffing them inside. They may show with some perfectionism or kind of OCD characteristics because they don't have control, or they don't feel like they have control over their environment. So they're trying to control whatever they can. And one thing that I think is super important to always remember, behavior is communication. There's a reason that students are behaving a certain way, and it's up to us to try to figure out why. Usually there's some sort of pain, frustration, anxiety, or distrust that's going on, which is why they're behaving the way they are. Very rarely does a student think, oh my gosh, I just want to misbehave to make that person mad. Usually they are communicating something. So, what can we expect as we return to school? I think the one thing that we can expect is that we don't know what to expect, except there's going to be a wide range of reactions. So some kids will jump right in like nothing's happened. For them, it's sort of been an extended summer vacation or one long snow day. And this is especially true for students who have had supportive families and they feel safe at home. But for others, they may have experienced trauma either through a strained or abusive family that have a lot of ACEs. Um, they may have had family members who were sick or even died from COVID. And for others, just the isolation itself can be a trauma. And remember, it's never clear cut what will cause a trauma response because two students can experience the exact same thing. One will have a trauma response, and the other one may seem as if nothing is wrong. So we have to be prepared for everything and anything. So let's talk about academic backslide. There could be lots of reasons for this. Some school districts may have had the ability to be more structured in their learning. They may have had some really strong distance learning put into place. Others, not so much. I know that in my child's school district, they had packets of work to complete while we were on quarantine, which, of course, if you don't have supportive parents, that would be a little more challenging. So I think family support, teaching methods really make a difference in this, as well as internal motivation. Um, so it's going to be really important as we get back to adjust curricula and instructional practices accordingly and really make sure that we do a thorough review of previously learned material. We may even need to provide extra tutoring or remedial work. And more than ever, it's going to be really important to use data to guide instruction. I thought that this slide spoke volumes. These are projections from the Northwest Evaluation Association. So they're the producers of the MAP test, and they predict that there could be significant backslide during closures. The solid line is typical growth and summer loss. So you can see students are learning, and then when you look at the last day, there is a slight decrease. Um, the dash line is what they call the COVID slowdown. So once school closures came because of COVID, everything sort of slowed down, but eventually it equals out. The dotted line is what they call the COVID slide. And this they did this prediction based on patterns of learning loss that are typical of summer and what students lose throughout summer closures. However, with the prolonged closure because of COVID-19, you can see that especially in the younger grades, students are losing a lot of their learning. And this is particularly true in math. Preliminary estimates suggest larger impacts in math. And so students may return in fall 2020 with less than 50% of their typical learning gains. And in some cases, they may have fallen nearly a year behind of what we would expect in normal conditions. Social challenges are typical to that we can expect are typical to what we see in children who have experienced traumas. They may be too clingy or may be withdrawn. We may have increased experiences of school avoidance. They may not want to come to school. They may be more argumentative with peers. We all know, especially for younger students, play facilitates cognitive development. So for them being isolated, this can particularly take a toll. And again, with modeling, if their social interactions with family members are strained or they were not interacted with while they were at home, this can also create strained relationships with peers. With emotional concerns, we can expect students to have a lot of grief. Grief over what they lost. It could be death of a family member, time home with family and not being exposed to peers, or even events such as graduations, um, or just going to school in general. And we know students, their frontal lobes aren't fully developed, so they don't always have the emotional control that we would hope or expect by adults. Again, these students may be impacted by their parents. So, students who have parents who have more difficulties with emotional regulation, they yell a lot and have a little more difficulties controlling themselves, are likely to come back with more emotional challenges. And as Carrie mentioned before, studies on people who were quarantined during previous medical outbreaks showed an increased psychological stress. So, irritability, anxiety, insomnia, poor concentration. So those are all things we can expect to see as we return back to school. Quarantine has also shown to significantly increase symptoms of people who are already diagnosed with mental health problems. So students who previously had PTSD, anxiety, depression, the quarantine could actually increase those behaviors. And other students may regress emotionally. So they may have left looking like a 10-year-old, but when they come back, they may emotionally behave more like a 6 or 7-year-old. Um, and again, emotional concerns may not only affect students, but also us adults as well. So it's important to remember and to remind teachers and staff that it's okay not to be okay. We all need to cope the best we can and to support one another. Many students react to emotions in a behavioral way. So I think it's really important to make sure that teachers and staff are aware that these can be common problems and that behavioral difficulties should be encouraged with patience and teaching coping skills. So we need to have a behavior referral plan in place. So at what point does a teacher refer and who would they refer to? So let's talk a little bit about what we can do to prepare for the return. What can schools do in the fall? First of all, we need to make sure that employees, parents, students know the proper procedures and have contact information for reporting academic, behavioral, or emotional concerns. And they also have to have the proper channels for reporting COVID positive cases. We need to make sure that every school district has their crisis plan in order. So you may want to get the crisis team together virtually if needed to revise or add sections regarding steps to take in case there's an outbreak of COVID 19 within your school district. And also, since COVID 19 exposure may require prolonged absences or additional quarantines, or we may even have families that don't want to send their students back, we have to have a plan in place that will provide education for students who need to stay at home. I think it's also important to have some sort of caregiver training for school employees and to help them develop a script or some sort of psychoed lesson that they can use in their classroom. It's important to follow medical recommendations put forth by reputable organizations like your health department, WHO, CDC, and in general, make sure that everyone knows to stay at home when sick. And if there is anyone in the school who has a fever or any symptoms of COVID-19, to make sure that there is an area in the school to separate them. Um, really make sure that proper hand hygiene um, is required by all students and staff. And one thing to consider, though, that probably isn't talked about a lot is annual school health requirements. The American Association of Pediatricians recommends that there is an extension for the due date for physicals that are recommended coming back into school because medical centers may be overwhelmed, either with appointments trying to get everyone to come back in or dealing with COVID cases, depending on the area you live in. And it's really important to get school health services staff included on the early stages of this planning for reopening. It's also really important to have a mental health plan in place. If you are a school psychologist or a social worker on this webinar today, it's really important that you be at the table when this is being discussed because you guys have the experience and knowledge to be able to help guide this type of plan. So teachers and school personnel should receive some sort of training as well on how to talk to and support children upon their return. It's also important, again, to make a plan for students who require more mental health needs. So those students that I talked about that are experiencing withdrawal, depression, anxiety, or behavioral concerns. And schools should make sure that they contact students who do not return to school and just make sure that everything is okay in the household. And also plan for school avoidance because this may increase as students return back to school. And then finally, publish and reiterate what to do if students express suicidal or homicidal ideations or if they report some sort of home abuse. So make sure that all staff and teachers know those protocols. So interventions in general, kids feeling safe is the number one thing that we can do to make them have a successful transition. These students coming back, a lot of them will be unsure. They're not sure what to expect. They've probably heard their parents talking about how schools will change. Um, so whenever you discuss, keep things to the facts, keep it age appropriate, and don't give your opinions or experiences because these could likely further stress the student out. Um, and next is to promote resiliency. So the number one factor in resilience is the presence of a supportive, caring adult. So we have the ability to be this adult or to promote it through our teachers and other staff. Reassure students' safety and that they're safe in the school district, and help children manage emotional regulation. Validate their feelings and encourage them to engage in activities that help them self regulate. So, things like exercise, deep breathing, self care, and any social and emotional learning that you have in place in your school district. When it comes to positive psychology, it's important to remember that all emotions are valid. But it is important also to focus on what is good. So while it can be real easy for us to kind of look at the negative and say, oh my gosh, I've been at home, I've been isolated. Well, focus on what is good right now. Do you feel safe? Do you have friends? Focus on the positive. Because often, if we don't have control over things, we are not sure what to do. So let's look at control. We may not have control over the coronavirus or who it impacts, but we do have control over social distancing, washing our hands, or wearing a mask. And focusing on that control is really important when things feel like they're so out of control. Gratitude is a way to foster happiness. So classrooms can start off the day with sharing moments of gratitude. So anything counts. It could be from the smallest thing you're grateful for to something that's huge. Savoring is another huge part of positive psychology, and that's taking the time to actually enjoy something. So, actually feeling the sun on your skin on a warm day, slowing down to smell the flowers, tasting each bite of a yummy treat, and not overlooking all those wonderful things that happen to us during the day that we don't take the time to notice on a daily basis. Kindness is something that can easily be promoted in a school system. The more kindness we show others, the happier we are. And the research has shown that. So if we promote a culture of kindness in our school, this will help everyone. And then, of course, self compassion. We're going to have times when we struggle, whether it's with attention or emotions, and we may feel sad or anxious, and it's okay. We have to have compassion with ourselves as we would with other people that we work with. It's also important to remember that while some students may not have been impacted, others may have lost loved ones or had people that they were sick that they were worried about. And it's important to remember that grief can be over people, situations, or things. So some students may be really upset that they missed a graduation or a birthday party, and these can be really hard for students who don't understand exactly what's going on. So listen, encourage teachers to listen, validate the students of validate the feelings of the students that you're working with, and as I mentioned before, avoid telling your own stories or giving your own opinions.
So now that we have an understanding of trauma and what we can do to help, how do we identify children who may need intervention? This is where trauma assessment comes in. I will provide a very broad overview of trauma assessment, particularly the current state of affairs in trauma assessment, considerations for trauma evaluations, and a discussion of specific instruments used in these types of evaluations. Trauma is everywhere, as we've been talking about. It's all around us, in our homes, neighborhoods, schools, and communities. Many of us ourselves have been traumatized in some ways and or know someone who has been traumatized. Over half of children will experience trauma in their lives. We've been discussing traumatic events throughout this presentation, and it's important to recognize how recent national events, including COVID-19 and social injustice, can result in trauma. Earlier this year, PAR conducted a trauma market research study. School psychologists, clinical psychologists, other psychologists, counselors, and mental health practitioners participated in this study. It was discovered that over half of the survey respondents are already conducting evaluations that include some assessment of trauma. And trauma assessments are initiated at multiple points, but most frequently during a psychological or psychoeducational evaluation. With the high rates of trauma, more trauma assessment in the schools is needed to identify children who need intervention and then to support them. So trauma assessment is important. As I mentioned, it's everywhere. We're currently experiencing a pandemic, which could result in trauma. Prevention and early intervention are the best interventions. There are 3 levels of trauma assessment. The first is universal screening. This includes a broad assessment of everyone, for example, a classroom or all students in a school. It's not used for diagnostic purposes, rather it helps monitor social and emotional functioning. So to do it, you want to identify the purpose of the screening ahead of time. For example, will you use it to identify students who need follow-up? Or will you use it to identify capacity needs in the school? As a side note, if you're interested in universal screening for your school, please reach out to Terry and she can show you what PAR can do to help. The second level of trauma assessment is individual screening. Children who may be at risk identified through universal screening or based on behavior concerns or at the request of a parent or school staff complete trauma screening instruments to determine if a full evaluation is needed. And then the third level is the individual assessment. This is the most comprehensive form of assessment. It can be used for diagnostic purposes, and it includes an assessment of trauma, but also other domains which can be affected, and we will discuss next. For more reading, I encourage you to review the NASP guidance for trauma screening in schools. As we learned earlier about the effects of trauma on the brain, many areas are impacted. So it's necessary to do a comprehensive evaluation to consider how trauma is affecting the entire individual. A comprehensive evaluation should include multiple assessments, many respondents, and multiple methods, including, but not limited to, a review of records, clinical interviewing, behavioral observation, and rating scales that assess a variety of areas, including trauma. Sometimes it may also be necessary to include cognitive, memory, executive functioning, and/or learning assessments as part of your comprehensive evaluation. Results from other service providers, including medical evaluations and social service investigations, may also be needed. How trauma manifests itself can look very different from one individual to the next. PAR offers specific books and assessments on trauma to help further your knowledge in this area and to meet your testing needs. The Trauma Essentials book by Drs. Kirby Wyckoff and Bettina Franzese provide a comprehensive view of trauma, including the history of trauma, assessment practices, and interventions for the home, school, and community. These authors have significant experience in the field working with children and adolescents who have experienced trauma. We also have a free white paper that addresses Dr. Wyckoff's motivation to write the book, the importance of assessing trauma, and ethical considerations when providing assessment and intervention. Dr. Steve Pfeiffer's book on trauma goes into the details about the impact of trauma on the brain in an easy to read and educator-friendly language. It clearly explains the brain functions affected by trauma. He offers educational interventions for trauma. This is a great resource for anyone who wants to understand trauma in children and how they can help. It's appropriate for educators, clinicians, and may be of interest to parents as well. PAR has several options for rating scales and screeners that assess trauma in young children through adolescence. For example, the Trauma Symptom Checklist for Children, or TSCC, is a self-report instrument completed by children ages 8 to 16. It assesses trauma and related domains, including anxiety, depression, post-traumatic stress, and dissociation. The standard version also includes a sexual concern scale and further breaks this area into sexual preoccupation and sexual distress. However, if you do not want to assess sexual issues or sexual trauma, you can use our alternative version, the TSCCA, which does not have any references to sexual issues. Validity scales are also included to help determine if a child is responding in a socially desirable manner or in a way that suggests a child may be exhibiting a cry for help. The instrument is easy to hand score, and if you're looking for digital solutions, we have it available on our PAR Connect platform through iAdministration and scoring that also provides a scoring report. The Trauma Symptom Checklist for Young Children, or TSCYC, is a form completed by the caretaker of children ages 3 to 12. It provides the caretaker's perceptions of the child's behaviors and experiences. And like the TSCC, it covers a wide range of trauma-related scales. It also includes separate norms for males and females, as well as 3 separate age groups, 3 to 4, 5 to 9, and 10 to 12. This is really important from a developmental perspective. The TSCYC also provides an optional PTSD diagnostic worksheet, which can aid the clinician in making a trauma-related diagnosis if needed. When the TSCC and TSCYC are used as part of a comprehensive evaluation, the clinician is able to obtain the child and caretaker's insights on how trauma is impacting the child. And as mentioned earlier, when we examine adversities, it's important to assess for strengths. PAR offers 2 strength-based assessments for children and adolescents, the SEARS and the RISE. So as I mentioned, we need to assess for strength, resiliency, and coping skills when we're doing these evaluations, because we also need to look at the positives. The social emotional assets and resilience scales, known as the SEARS, is one of these strength-based assessments. It measures strengths and resilience and has 4 scales on it, including self-regulation, responsibility, social competence, and empathy. These areas assessed are all important for success at school. PIR also offers a variety of assessments that can be included in a comprehensive assessment of trauma. The short links are listed here. I'll highlight some of them. The Brief 2 examines executive functioning. BEARS 2 is a behavioral and emotional rating scale. The CHAMP looks at memory, which can also be affected by trauma. The PSI-4 is a measure of parenting stress, which is especially relevant during these times. And the PAIA is an adolescent measure of personality. Also, on the right-hand side of the screen, we have some of our Reynolds products, which are narrowband assessments, and they cover depression and anxiety in children and adolescents. So some final notes about PIR assessments in general. We realize that due to the pandemic, assessment practices have been changing and we want to help. So we've developed some guidelines for telehealth practice using PIR products. Many of the rating scales discussed today can be administered remotely. Clinicians have also expressed concerns about using paper and pencil materials during these unprecedented times. So alternatively, you can use on-screen administration and scoring if desired in lieu of paper and pencil. We have remote administration versions of cognitive measures available, including the RATE and TOGRA, and the RIAS-2 and RIS-2 are coming soon. And finally, PIR is in the process of converting many of our paper and pencil stimulus books to an electronic format for our customers.
Okay, so what's next? What do we do right now to prepare to get back in the fall? First of all, educate yourself. So you're already off to a good start by attending this webinar, but read up on the best ways to support students as you come back, their mental health needs, their educational needs, and be confident. For those of us who are school psychologists or social workers, be confident in what you learned during your graduate school studies. A lot of students want a listening ear, and we have that, so we can definitely give that to them. Educate others. Although it's not necessarily our sole responsibility to educate teachers and staff, we do have the knowledge about mental health and what to expect when students return. So the more we can share resources with teachers and staff, the better off we'll be, whether that's through presentations, newsletters, email updates, or just sharing some links that I'll share with you in a minute. It's important that teachers feel equipped for dealing with students and their varied responses when they come home, come back to school. And again, participate. So invite yourself to the table. School psychologists, social workers, we're uniquely trained to help support mental health needs of students. So if you're not invited, invite yourself. So this is a great resource. It's the NASP Health Crisis Resource, or the COVID-19 Resource Center. So there's sections on how to return to school, special education, crisis and mental health, and even things for families. When you go there, be sure to check out the ASCA NASP School Reentry SEL Considerations Guidance. That's a lot of information. But NASP partnered with the American School Counselors Association to come up with a wonderful resource on social and emotional considerations on returning back to school. It's the first link that's under crisis and mental health. Here's a link to the CDC resources for K to 12 schools. So there's guidance documents on how to plan, prepare, and respond to COVID-19. So whether it's prevention and support or even printable posters that you can hang up around your school, they have a lot on health in this site. This is a wonderful site from George Washington University. It's the Center of Health and Healthcare in Schools. They have sections on guidance for school settings, prevention, action, nutrition, cleaning, self-care, and mental health. So there are lots of links on here from other organizations like Child Mind Institute, NASP, and the CDC, all kind of put in one place. And then this one is fairly new. It's just popped up in the last few weeks. It's the National Center for School Mental Health, and it's created by the University of Maryland, and they have wonderful documents on how to plan for the upcoming school year. So whether it's wellness and mental health, technology support, or just how to prepare, they have great information on this site. And then finally is self-care. It is so important that we take care of ourselves. Most of us go into professions such as school psychology or social work because we care about others. We want to help others, but we carry a unique burden because by caring for others who are struggling, it's often easy to overlook our own needs. So self care is important. Be sure to take care of yourself. We've all heard um, the example of when the masks fall down in the airplane, you're supposed to put on your own before putting it on your child that's sitting next to you. So make sure you take that mask. Take the time to learn how to take care of yourself, and this is a great resource to help you do that. So the final slide that we have here, I just love this little cactus on the right hand side because I picked this up on one of my trips. It was a magnet, and I was like, oh my gosh, these are the students I work with, are they like this little cactus right here. They want the hugs, but they're really prickly and hard to hug. And I think that we'll have some students that come back that way. They want support, they want to feel safe, they want to they want the love, but they're going to make it a little challenging with their little spikes. And I also love this quote. Remember, everyone in the classroom has a story that leads to misbehavior or defiance. 9 times out of 10, the story behind the misbehavior won't make you angry. It will break your heart. So that is the end. I had asked that anyone who has questions to put them in the chat. Also, I would like to mention that we will be sending out a survey within the next couple of days for all the attendees. So please take the time to complete this. It's going to be super short, 6 to 8 questions, and it's going to give us a good idea of how we can help in the future and different topics that we can help bring to you. So please take the time to fill that out.
So it looked like we had a couple of questions. Someone had asked if this is being recorded and if they would be able to watch it later. So the answer to that is yes. We will get that link out there and have it available for people to see. We will follow up with the participants and we can send out a link for the video. Someone else also asked about the slides and if they would be available for download, and we can certainly make that available to everyone as well. I know there's a lot of informative information and links on there that you then would be able to easily access. So Terry and I would like to thank you so much for joining us for this webinar, and we hope that you have learned some valuable information and have thought of 3 things that you could take from this presentation and apply as you move forward. So thank you for joining us and have a wonderful day.
Thank you.